Morning, everyone. So I'm going to take over from where Sahil left out in terms of the evolving data of Limus-coated drug-coated balloons in the European and Asia Pacific countries. So we have a lot of data. These are my disclosures. A lot of data emerging on these devices, but these are really data that we are hoping to bring to the U.S. with some upcoming randomized trials. So just to remind you, for all the cardiologists in the room, and all those interested in coronary intervention, we used to be a paclitaxel-based strategic intervention group. We used paclitaxel stents in the 2000s. This really changed and evolved the drug-eluting market, but we did find that Limus tended to be a more efficacious drug therapy, especially with the polymer on a stent. And you can see here when comparing the Cypher drug-eluting stents to Taxus drug-eluting stents, there is an improvement in angiographic restenosis, target lesion revascularization, pretty neutral on stent thrombosis, except when you go out longer, we actually were seeing scaffold thrombosis with Taxus stents. And you've seen these slides before. I just want to highlight a couple key components of why Limus might be the right drug moving forward for the infrainguinal space. Again, the ability to more effectively inhibit smooth muscle migration, but really the unique property of Sirolimus versus paclitaxel is its anti-inflammatory component. Again, as Sahil showed you, when you have barotrauma from balloon angioplasty, and you do not plan to put a scaffold down, you need a rush of drug to improve both the thrombotic and inflammatory pathways that occur over days to weeks after barotrauma. And so the hope here is that the Limus can help stabilize that barotrauma, prevent early inflammation, early migration, and early restenosis. Last component here that's different is the cytostatic versus cytotoxic differences. So again, paclitaxel kills and Sirolimus arrests. And so the thought here is that we can avoid some of the trauma with a paclitaxel-based cytotoxic agent by just arresting cell growth instead of destroying cells. So just lastly, before I should show you some data, it's challenging to get Limus, as you heard also, into the arterial wall. The nice thing about paclitaxel is it's lipophilic. It moves into the adventitia without much challenge, but it does tend to kind of partition and spread out through that layer without consistency. Whereas if you can accurately deliver, and you've heard about encapsulated Limus into the vessel wall, you can get a more subtherapeutic diluted down vessel, but spread out throughout the length of it, and hopefully with good retention. So let's spend a minute looking at some data from outside the US. So I'm going to highlight two devices that are now commercially available outside the US. Concept Medical's Magic Touch Balloon, which has a very prolific research program, as well as MedAlliance's Solution device. So this is really thanks to Eddie Choke. Eddie had done a number of really pivotal studies with the Magic Touch balloon. His main study was the Extosi study. So this was a 50-patient CLI cohort that combined both femoral popliteal and below-the-knee disease. And I'm going to show you just some evolving data that's come from his program as we've seen it over the few years. So as you can see here, the early benefit, again, for CLI with a Limus-based drug-coated balloon demonstrated really an optimal primary endpoint at 6 months that included patency, freedom from CDTLR, and amputation-free survival. All these numbers in the 80s to 90s for femoral popliteal. And you can see even for below the knee, we're getting CDTLR rates greater than 85, which is quite remarkable. And as you followed these patients out through 12 months, you can see that these benefits were really preserved overall. And again, this is both for femoral popliteal and below the knee disease. So he's been able to continuously provide us the data that we're asking, which is how much further can we push Limus-based therapy. You can see here out to 24 months for below the knee. We maintain a real good CDTLR rate of 85%. He has an impressive program where they really optimize limb salvage, not discharging patients until they're ulcer-free, and he had a 91% limb salvage rate at 24 months. And this is coupled with SFA disease, again, of limb salvage of 94%. More recently, he published in the Annals of Vascular Surgery the 3-year data from the Extosi study. And again, just highlighting here the persistent benefit. So you get that early security of preventing restenosis, and it's now sustained in terms of its clinical impact. And you can see a freedom from TDLR of 84% through 3 years, as well as a freedom from amputation of 86% through 3 years in this cohort. Now, the one downside of using the Extosi study to extend what we know about Limus balloons is we don't have a control group. So this is very helpful data, but he moved on to a new study called the HOPE study. And in this study, the HOPE study compared retrospective patients treated with PTA alone versus the Magic touch sirolimus-coated balloon. And you can see when comparing these two strategies over time, and again, for us in the US, that would be an equivocal experiment here because we don't have drug-coated balloons. You wouldn't choose one patient over another. It's just about what's available. There was significant benefit at 2 years, again, from freedom from TLR, favoring the Magic Touch sirolimus-coated balloon. Very nice amputation-free survival rate of 69.5% at 2 years that outperformed PTA alone. I just want to highlight the solution program as well, and this has continued to really provide additional data that Limus is moving in the direction of being our preferred drug. In the solution SFA trial, you can see nicely freedom from TLR rates through 2 years, and the figure on the left approached 87%, again, pretty close to what we're seeing, if not comparable to the Magic Touch balloon. And then also really nice safety profile, no deaths, no minor or major amputation in 50 patients, and Thomas Zellers here who initiated the study. When you look at below the knee critical limb patients, again, this is out through just under 1 year, but a nice freedom from CDTLR rate of 83%, amputation-free survival of 84%. Lastly, I just want to highlight JET this year. There was the extension of the Solution SFA Japan program. This was the initial publication that was in JACC Interventions, 134 patients with femoral popliteal artery disease. And again, you can see in this Kaplan-Meier curve, very impressive primary patency rates of 87.9%, freedom from TLR of 97% in this study. And these were the data presented at JET. I could not find the figure anywhere, but I can tell you the primary patency was 83%, freedom from TLR was 94.5%. The other question that I keep kind of coming back to in my head is, are we going to be shifting our stent scaffolds to Limus-based therapies? As you know, right now we have two drug-coated or drug-eluting stents for the femoral popliteal segment, the Eluvia drug-eluting stent and the Zilver PTX. And so we've seen a number of these Limus-based stents come and go. This was one study from the Illumina study looking at a novel scaffold with Limus-based coating, and you can see in the table on the right that this really matched what we're seeing in terms of patency for the paclitaxel stents, but avoiding what at the time was a concern about paclitaxel in the safety controversy. So we'll see. I haven't heard much about the stent since these data were published, but we might be seeing our whole portfolio of therapies move more towards a Limus-based approach. Thank you very much. Look forward to interacting with all you this morning.